Ah, thank you. The first slide there, please. I just want to sort of put South Sudan in perspective for you and give you a little bit of the history because it's a very important country in terms of onchocerciasis. And it's also a country that is in great need of support and activities if we're to reach elimination in Africa. And I give you this as somebody who has worked there a long time, and I have the honor at the moment of being the chair of the steering committee. Can I have the next slide, please? So it still has disease, including eye disease. We tend to think about that onco eye disease has disappeared. It hasn't. And there still is both skin disease, eye disease, and the associated epilepsy and Nakalanga and disease is bad there. But like a couple of other countries, DRC particularly, there is still eye disease present in Sudan, particularly in the West. The entomological situation is largely unknown because hasn't since the 80s been a really intensive entomological investigations there, except for a couple of sites where we know there are dams and concentrations where we know there are breeding, where there's been research, but essentially we really don't know the transmission zones in any detail. There are many difficult major cross-border areas, and it's very pleasing to have some of the countries present. Perhaps the most important one, unfortunately, can't be with us today because of what is going on in Sudan, but that border with Sudan in the north is extremely critical to both countries in terms of addressing onchocerciasis. There are areas that are co-endemic with lymphatic filariasis and areas that are not. Although I would say that the prevalence and intensity of infection is highest for onchocerciasis. And it goes without saying that as a result of the history and the civil war, there's a poor infrastructure in many ways. Roads, very few major roads. So it's a very challenging country. Have the next slide, please. So just to give you phases in the history of South Sudan. In the early days, in fact, that photograph I showed you in the beginning was the Jura River. And in the 1920s, it was then labeled as Jura River blindness, where the people living near the river or working near the river, particularly the ferrymen, was recorded by the medical administration then, who happened to be in the colonial administration, as having Jura River blindness, a name which persists in Sudan today. In those early days, so I'm talking 1920s, 30s, well, 30s, 40s, the eye disease in Khartoum had clinics across the country and had a treatment that was known as the Sudan regime, which was really awful, to be frank, because it was Suramin, and once a week for 6 weeks, an injection of Suramin, which people quite often never reached the 6-week time, either for some reason. So there was an effort, and there are clinics that have been there for a long time that were known as OV clinics. In the 1980s, there were intense activities in the country, and at that point, the country was Sudan. Had not South Sudan had not been born, and epidemiological studies were carried out. But a lot of the early work on the effects of DEC were carried out in Bahr Ghazal, in WOW. The early studies on the classification of oncodermatitis were done in WOW. So there was a lot of activities across the South. In 1995, the Carter Center, Jimmy Carter, had a ceasefire in the Civil War to distribute ivermectin, and that was the first time in the South that ivermectin was distributed. And that was when APOC came into being and was involved with mapping and distribution of ivermectin, although investigations showed there wasn't a very high coverage of MDA. MDA did start to become more organized in 2014 when funds started to become available, and NGOs committed themselves to working there, although there were NGOs involved before in the APOC phase. And a national plan was developed in 2014. And in 2015, there was organized distribution, which is the phase that we're in now. And I'm sure Yak is going to talk about, and the work that's carried out, particularly with the two major donors, major implementing partners, CBM, Mentor, supported by their own funds, and the End Fund as supporters for the country. So that's really the history. Go to the next slide, please. So what is the importance of the disease? And this is something that we as a steering committee are trying to focus on as a country that needs help. Together with a few, as I've said, with a few other countries, it still has disease. So there has to be a consideration that there is disease taking place, where including the epilepsy nodding syndrome, and there's a high prevalence of it, and of the epilepsy and nodding syndrome in certain places. And partners like Amraf are distributing drugs to try and help children with epilepsy. I'm not going to get into any comments about whether this is onco strictly or not, but there's certainly a lot of evidence to support that we really need to consider that it might be. The country has many difficulties, continuing difficulties, and those are not going to change because some of them are things like environmental changes that have environmental challenges, I should say. So getting high coverage is often difficult. And this is one of the major reasons. Migration, insecurity still exists, but the cross-border issue, as I've mentioned, is major. So it's important that we have data on the ongoing status of infection. And this is one of the things that the steering committee is trying to ascertain. Have been quite a lot of MDA, but we don't know really the level of infection. And the map really is something that needs to be considered. Call it OEM, call it whatever you want. But we do need to have data associated with that. And I think one more slide. The next slide, please. So I was going to be talking after Yak Yak Bol, but I'm sure he's going to cover some of the important needs for the program. But the major thing from the steering committee's point of view is that we really need to know the current status of infection across the country. Really, where is the country in terms of endemicity? There has been no entomology, and particularly breeding sites mapping, and that's something that we put high on the list of needs in the near future, which ties in with OEM, because breeding sites go along with OEM. So my last comment is that it's a country that still needs much support, and it still has serious onchocerciasis, meaning clinical as well as just levels of infection. So that's my my presentation, Didier.
Thank you so much, Professor Charles Mackenzie. We are going now to give the floor to Dr. Yak Bol to present the program to the group and some of the coverages, some of the challenges, and some of the activities conducted over the last 10, 15, 20 years. Yak, you have the floor.
Thank you very much, Didiri, for this opportunity. I'm Yak Bol. I'm the National Coordinator for PC NTD, Minister of Health, Republic of South Sudan. I'm grateful that they're gonna have given me this privilege and opportunity to present the progress.
Yak, we are running behind the time. Please go straight to the point. You have 20 minutes, please.
Sorry?
You have 20 minutes maximum. Please go straight to the point.
Sorry, are you hearing me?
Yes, please. You have 20 minutes.
Okay, thank you very much. So, next slides. Yes, this is a brief outline of my presentation. It will talk about the background on onchocerciasis in South Sudan, elimination committee, and is already discussed by Professor Charles Mackenzie. So I will not go about it. I will take a few look onto that. Treatment and geographic and epidemiology, then implementation plan for 2023. And then I will look into cross-border cooperation issues. Then the challenges that are facing the program in South Sudan. Next slide, please. When we talk about background on onchocerciasis in South Sudan, just the basic is population of South Sudan estimated to be 12,444,08018 based on the projection census of 2008. And it has been given projected until today. So this is the last update from the country in 2023. Administrative unit in South Sudan, we have 10 states, and we have 10 counties, which other countries are calling districts, 80. Onchocerciasis is endemic in 9 states out of 10. We have 48 counties that are district as well are endemic for onchocerciasis. 33 out of 80 are proposed for onco-elimination mapping. Population at risk of the onco-endemic areas in South Sudan is 8.8 million people. If you can see this map, will show to you the onco-endemic areas that are light blue colors. And then you see the white area in the map are those counties that are proposed for onco-elimination mapping. So that is all about this map. Next slide, please. Continue on the background. The first REMO exercise was done in 1997. And it has, sorry. All right. It was done in 1997, as said by Professor Charles Mackenzie, and it covered only seven villages in South Sudan. This provides the best scientific evidence of onco-endemicity in the country. In 1997, 5-year proposal plan was submitted to APOC to provide additional financial resources for implementation of CTDI. In 1998, up to 2003, the HESNet International, that was the NGO, was tasked, took off a role as the APOC partner to implement the intervention in South Sudan. This is during the war, the first civil war in Sudan then. Between 1998 up to 2002, the HESNet conducted a rapid epidemiology assessment in 285 villages. Next slide, please. And you can see this picture is Charles Mackenzie, is Dr. Adian, sorry. Continue background. In October 2000, the South Sudan Onco-Care Task Force was created because the Khartoum-based National Onco Task Force could not access the SPLM control area to carry out their responsibilities of monitoring and supervision. And this is during the first civil war in South Sudan. In July 2023, South Sudan Onco-Care Task Force Secretariat moved from Nairobi to Rumbek in South Sudan. The same year in 2023, APOC began her first REMO survey in South Sudan. And due to prevalent insecurity on that time, that everybody was known, only 23 villages were mapped. So South Sudan Onco-Care Task Force later add additional 36 villages. Then APOC subsequently adopted in 1997 the REMO data in 7 villages and validated in 1998 up to 2002 by REMO data in 164 villages for REMO data. Those are the villages that was covered by REMO data. Next, please. Next slide.
Excusez-moi, vous pouvez ouvrir votre micro, monsieur Yakbol, s'il vous plaît. S'il vous plaît, monsieur Yakbol, votre micro est déconnecté.
Yak, kindly open your microphone.
What muted me? Hello, are you hearing me?
Yes, please, go ahead.
Okay, this is a structure of onco-care program in South Sudan. You can see at national level, there's a director for PCNTD, which is reporting to under the Director General for Preventive Health Services. And you can see here the partners here are WHO, CBM, and MANTA. And they did the partner for onco-care. Then the National Coordination, onco-care and lymphatic filariasis. And then when you go to state level, you find all the 10 states with the program officers. And then you go also at county level, which is the district level, you find also each county NTD supervisor at county level. And then you go down to the Payam supervisors, you find it's like Payam entity, Payam supervisor level. So, and go back up to the Buma. For example, you want one Payam supervisor supervise 10 Buma supervisors. And then you go to the community level. Next slide. Okay, has been said early. This is ONCO and LF Elimination Committee that was reformed recently this year, because in the past used to be more than 20 members, and we see that is not effective. So we all of us agree that to reduce it into only 6 members under the leadership of Chair Professor Charles Mackenzie, and then the vice chair is Dr. Tang Chir, and then Dr. Adrian, Mr. McCoy Samuel, who is the former director for program, and then you have other members here with Dr. Norma from Sudan, and then you have Dr. Yata from University of Cuba. Those are 6 members that form the current elimination committee. It's a small committee that can deliver, can be effective, and review and advise the program. So it was established in 2019 for ONCO and LF, and then reconstituted in the last quarter of 2022. It consists only of 6 people, national and international experts in a different field of the health. First meeting was constituted was held in February this year in Juba, where those new members come together in one meeting. The key issues for consideration is inaccurate population denominator, and this is the major issue here. And I think it was mentioned by Professor Charles Mackenzie. If our 2020 mistreatment round, OncoCircuit's elimination mapping, and then biannual treatment selected IUs. Then LF transmission assessment survey, LF MMDP scale up, integrated of CDD with BHI and malaria program. Those are the key issues that has been discussed during the meeting, the last meeting of ONCO Elimination Committee. Next, please. Oh, this slide is on our ONCO elimination activity. Yeah. This is ONCO elimination activity from 2017 to 2022. If you can see here in this column, the intervention started in South Sudan in 2017. That is the real intervention under the leadership of South Sudan. The number of counties targeted by then was 17 only, and the national coverage was only 35.4%. That is around 17 counties out of 48 which are endemic for ONCO and LF. The donor here was, the partner was Site Saver by then, Manta, and then CBM and WHO. It continued in 2018. It has increased to 19 counties, and the same partner support the intervention. In 2019, it will have increased up to 22 counties, and then the coverage, the national coverage increased to 45.9%. The partners were CBM, which have delivered intervention in 18 counties, and WHO supporting 4 counties. In 2020, there were no intervention in South Sudan due to COVID-19. In 2021, for the first time, that the county managed to treat 40 out of 48 counties in South Sudan. The coverage, national coverage was over 80%. It was only CBM alone. In 2022, this is the first time in the history of this country that we managed to treat all 48 endemic counties in South Sudan. Those are the counties that are non-endemic at the moment. We all of them treat them, and we consider that we achieve 100% geographic coverage. And the partner was CBM, supported 42 counties. Manta supported 7 counties.
Just
now
a
for
reminder,
2020.
a reminder, you have 5 minutes left.
Oh, exactly. For 2023, we have, because due to the inadequate funding, we are planning only to treat 32 counties. Next slide, please. Next slide. Yes, you can see this is a mass drug demonstrations. Mass drug demonstration in 2022. The MDA was conducted in May up to September last year. Some part of the country were flooded and not adequately covered. There was a lot of migration of population in the county that we know very well due to so many reasons, especially the counties that are bordering Uganda, Sudan, and Ethiopia. The counties that bordering Uganda had ongoing conflict, and CDD sometimes face a lot of insecurity in those areas. Of course, as I say earlier, there is a denominator for coverage was based on the projected population of 2008, which is not accurate in most of cases. The reported coverage of Magui, for example, was 48%. But when the coverage survey was conducted, it was 63.7%. That is mean that with all the displacement, the old people who are present in the county, most of them receive the treatment. Those are the areas that you can see in this mapping. Those, the green reflecting the more than 65% epidemiology coverage, and the red is below 65 epidemiology coverage. Next slide, please. Yes, this is a trend. Then I cannot read them all. These are the all counties treated in 2017 up to 2022 with the all cross-border issues. The counties are bordering some of the countries that are least there in the cross-border column. Next slide, please. Yeah, this run of epidemiology coverage since 1917 up to 2022, with also the cross-border countries to South Sudan. Next slide. The same because we treated 48. So this is a list of 48 counties. Next slide. This is a treatment plan for 2023, which is important for us as a movement. If you can see, the MDA will be conducted in 32 counties or districts from May up to June this year. Those counties are only get the funding from the major partners, the CBM through NFAN, and then from Manta through NFAN as well, and then only 6 counties from Arise. And now we get a pledge from WHO to treat around 9 to 10 counties also. If we add those 9 or 10, we'll be able to treat 42 counties in 2023. But the plan is still on the process to submit a proposal to WHO to get the funding for the more 9 or 10 counties for 2023. 16 counties missed the treatment in 2023. This is the initial plan before we could add those counties that will be supported from WHO. So we have like 16 counties that are lacking the funding. 5 out of 32 counties will receive a 2 round of MDA. Those counties are with high prevalence of Newton syndrome, for example, in Western Equatoria. And some of them are the counties that are cross-border with our neighboring countries. The independent coverage evaluation survey will be conducted in only 6 counties. And if we add the 10 or 9 counties from WHO, then we can have more 2 counties to be added to 6, they will make 9. Those are this map, you can see those countries that will be treated in 2023 and those that have no funding for 2023. Next slide, please. Next slide. Yes, these are cross-border issues. If you can see now, we have active cross-border collaboration and coordination with Uganda. So you see all those activities that has been conducted since 2001 up to this year. So we have advocacy and planning meeting that was done jointly, and we have a joint communicate with Uganda, and training on river perfections and OB16 testing, which is ongoing in Kaji County, and then in Magui. And later on, it was interrupted due to the insecurity, but they have resumed last year. Entomological activity also is taking place in Magui, only in Magui County. And then there is a plan also to resume training. The flight catchers were trained in Magui, but they were interrupted due to insecurity. Mass drug administration also, we are conducting drug administration first time cycle in Kaji in 2020. And in 2020, it was the beginning before the epidemic. The drug distribution was done in Kaji in March. And then in Magui, for Magui, it was suspended due to COVID because it was late. After that, the lockdown was done. There were no community-based intervention. So the second MDA cycle in Kaji was conducted in 2021. And the third one was conducted last year in 2022 in Magui and Kaji. That is mean that the most counties that are concerned with Uganda have been covered with mass drug administration in the last 3 years. Plan is in the place to start biannual treatment in Kaji this year. Next slide, please. These are continuation of cross-border issues that is very important to mention. We have several meetings conducted in cross-border collaboration with Ethiopia and Sudan. However, there is no implementation on those recommendations due to the lack of funding for cross-border activities. This is well known. We have continued having a meeting for the last 3 years on cross-border issue with Ethiopia and Sudan. Unfortunately, there is no single recommendation that has been implemented, except the continued communication until recently. Until this year, the communication is ongoing on, only lacking funding in order to plan together and try to harmonize all our activity along the borders. There is also the plan going on to establish the cross-border coordination with DRC and CR. This year, I managed to meet with the NTD coordinator in DRC, and then we agreed that we have now to start planning together because we have a very big areas that are linked to Congo. And as well, our side, all counties that are bordering DRC are endemic for onchocerciasis, but the treatment has been going on for long. And I expected the same thing is happening on that side. But unfortunately, we could not able to have a second meeting that was planned to take place last month. We have also other issue of language challenges here. It's very difficult for me to coordinate directly with my counterpart in DRC because of language barriers, but we want to look for other alternatives that we can be able to communicate. Next slide, please. The opportunities and strengths on the program. We have a strong commitment from the government leadership at all levels, and that is the most important thing. Improve security situation across the country. This provide access to the program last year to money to reach all endemic areas because there is a little insecurity that was provided by the government to all places. So allowed us to treat all endemic county last year. And I hope the same situation will continue in 2023. High acceptance of IBM treatment in the community. Our community are really ready to receive the whole treatment. There is no refusal. A refusal completely sometimes is very personal, very few. But most of the community are ready to receive IBM without problems. Adequate supply of IBM for MDA in all endemic counties. Availability of BHI system for sustainability. We have a BHI system with a community-based structure in this county. It's covering each of every boomer in the county. These are the opportunity that the program need to make use of it, and we make use of available structures or BHI in the community. And this one will will give a strong strength to the program, because if we are talking about sustainability in the future, these are the structure that we are planning to use them. Technical support from Elimination Committee, that is really very great. We are receiving a technical support from Elimination Committee, which allowed us to direct the program to right directions. Technical support from WHO and partner. This is the continue, because WHO is our right-hand side here. It's providing a technical support whenever we request it. Then the funding from ARISE. Funding from ARISE also is giving a lot, not only to onchocerciasis, but also to other entities such as trachoma. Next slide, please. Yes, of course, this thing will not end without some of the challenges that are facing the country. First, inadequate capacity for domestic resource mobilization. At the moment, we don't have a clear strategy on how the country, the program will be able to mobilize the resources. And this is the major challenges that we are facing. Lack of accurate population denominator for estimated treatment coverage. And this is the major things. When you see the treatment that a trend that I have shared with you earlier, there is a lot of issues. Most of the country are under treatment. It is simply because there's a lot of displacement. The population are not in the place due to the insecurity, due to the flooding. Our population are refugees in Uganda and Ethiopia and in Sudan. This makes this the baseline that we are using not even useful to provide accurate information to the program. Human resources and some national and county supervisors are not MOH staff, and that is a big challenge here. We have a staff here who are not employed by the government, and sometimes the commitment became very difficult because we are not able to motivate them to keep them in the program. That make a program vulnerable all the time. We are trying to approach the government to employ everybody who is working for NTD so that he can be able to get a support. Planning and implementation of onco activity not integrated with the community health system, Boma Health Initiative, for example. At the moment, we have a program that is not yet integrated to the health system of the country. And this is a big problem. We are trying this year. This year, we participated in the government 5-year strategic plan, and we try to integrate the old NTD planning into this next strategic plan that will start in 2023 and 2027. I hope that one will be the first step that the NTD program will be a part of the structures of the government of South Sudan. And definitely, this is where we will be able to get even the funding through the national budget. Inadequate capacity at national county level to cascade the training. This is a challenge that is continuing because we have turned over the staff that are not maintained due to so many issues, due to issue of motivation and all those things. And the few who are available, who commit themselves to the program, also they have low capacity that they need to be supported to raise the level of the task. For recording and record keeping and reporting. If you come to this program, this thing we started this year try to put the system in the place. You will not find the documentation.
You have 2 minutes to wrap up, please. 2 minutes.
All right. Yes, exactly. Inadequate financial accountability, inadequate capacity for robust logistics of the medicine, inadequate capacity of monitoring and evaluation at national level, and NTD data management not integrated into national DHI system, lack of transport mean for supervisor. Next slide, please. Next slide, please. Yes, those are critical actions. The critical action, if you can, I list them, I divided them into four. If geographical coverage, you say inadequate funding to achieve 100% national coverage. What do we need to do here? Advocate for WHO and they're going to use this platform and ARISE for funding of 16 counties that are still lacking of the fund at the movement. When you come into numerical coverage, the population displacement, inaccurate denominator, inaccessibility to some of the villages, flooding, insecurity, adequate capacity at national, state, and county supervisors, inadequate transport, and then increased demand for high incentive by CDDs. Due to the current economic situation that we are forced now to continue increasing the incentive to attract the CDD to distribute the medicine. The proposal action here is to improve cross-border coordination, proper timing of MDA dry system, technical support from Ghana, which is this platform that we are presenting this presentation, on capacity building for national supervisors, advocate with the MOH and partner, integration of the national health system. So M&E and data management for recording, reporting, and recording keeping, inadequate capacity for M&E at national level, lack of framework and plan for M&E on OncoLF. What is the proposed action? The proposed action is technical support from WHO and Ghana for training on a data management, monitoring and evaluation, technical support from WHO and Ghana and Chai. Chai recently is set to support the South Sudan to develop a monitoring and evaluation framework, and then development of indicators that will be ready now to be integrated to the AI system. But unfortunately, we don't have funding to integrate those indicators where they are completely developed to the AI system. Sustainability, human resources not in the MOH payroll, data not integrated to DHIS and DHI2, inadequate capacity for domestic resource mobilization and contribution, inadequate integration to BHI system. The proposed action point here is technical support from WHO and Ghana is required for integration into Boomer Health Initiative and DHI2. Technical support from WHO and Ghana for domestic resource mobilizations. Next slide, please. Yeah, thank you very much. And this is the few things that I would like to share with the forum. Thank you very much.
Thank you so much, Dr. Yak, for the time, and congratulations to the team in South Sudan for being able to produce those results and take the program forwards, despite some of the challenges that we all are aware in South Sudan. And I'm really sorry to be a very tough timekeeper, because if I don't do that, it's going to be very difficult for all of us, since we have other commitment and meetings after this meeting. I'm going to pass now the floor to two donors / partners who supported South Sudan. The first one will be Yohan from CBM, and the second one will be Dr. Kamal from Mentor Initiative. We have a recorded presentation. I'm going to ask my colleagues, the IT, to share the recorded presentation, both for Yohan and Kamal.
Hello, everyone. It's great to meet you all online for this meeting. My name is Johan Willems, and I'm representing the Christian Blind Mission, also known as CBM. I will talk just for a few minutes about CBM's role as a partner from the Ministry of Health in South Sudan. That I'm using 3 slides only. CBM supported psychiatrist elimination in South Sudan and 4 other countries: Burundi, Democratic Republic of Congo, Libya, Central Africa, mostly as part of integrated NTD programs, where we also support the elimination of lymphatic filariasis, trachoma. This is the collaboration in South Sudan started in 2006 with the African Onchocerciasis Control Program in collaboration with WHO. In this partnership, CBM's role was to provide technical and financial support for the implementation of drug administration campaigns with McKizan. The technical support either technical coordinator directly with the national coordination team. Unfortunately, this collaboration was interrupted during the height of the civil conflict from 2004 to 2016. As you can see in the graph, the annual treatment numbers have increased gradually over the years, with a decline that towards 2000. After the closure of APOC, the partnership with the government was with the objective to support the nation of Congo. Since then, reported numbers of treatments have gradually increased again, thanks to funding from civil resources, donors such as the Infant, Artesian Church, Mexican Religion, and the British government invested for 1 year only. Meanwhile, the technical support is provided through a CBM in-country team of program officers and coordinators. But again, unfortunately, two disasters affected the program seriously. There was the COVID-19 pandemic, causing interruption of treatment in 2020, and there was the sudden death of the Ascent program in 2021. On the other hand, the positive side, the implementation of the national revitalized peace Sudan to reach areas that couldn't be treated before. This post-conflict context, together with upscaled support from the End Fund, engagement from the Mentor Initiative, and CBM resources, the program was able to achieve 100% geographic coverage for the first time in 2020, reaching to nearly 6.2 million persons at risk. The first graph here is showing the gradual upscaling over the past years and the proportion of implemented partners. In the graph, one bar is standing for all implementation units in need for mass drug administration. A similar graph is showing the CBM funding partner shares, with CBM at the red bar, End Fund in brown, and Mectizan and donation program and Ascent bars. For 2023, the ARISE consortium is supporting, for the first time, onchocerciasis elimination in 6 counties co-endemic with lymphatic filariasis. Despite this new engagement from ARISE, stepping in where Ascent left behind, there are challenges to sustain 100% geographic coverage. Currently, the national director is negotiating with other partners with the aim to fill the gap. Through all the years, CBM's approach is focused on health system strengthening and community-directed interventions. Mass drug administration is a public health intervention. Therefore, capacity support is provided at all levels. Through this health system strengthening approach, the NTD program has been a major driver on rebuilding the health system in the post-conflict context of South Sudan. Through strengthened health systems, all other health programs can be delivered. The community-directed interventions are adhering to the CBM principle of inclusion of persons with disabilities, making sure no one is left behind, striving at gender equity and social inclusion. Our support is aiming at integrating with other community health programs such as the BOMA Health Initiative, patient care for lymphatic filariasis affected persons, nodding syndrome and epilepsy patients, and eye health programs. Since its creation in 2019, CBM is an active stakeholder and supporter of the Onchocerciasis Elimination Committee. Together with the National Coordination and the Expert Committee, we are very much looking forward to the next steps on the pathway to elimination of onchocerciasis. Alongside sustaining mass drug administration, CBM is aiming at supporting elimination mapping, pre-stop MDA assessments, and delineation of active transmission zones. CBM will continue to promote increasing country ownership, further integration, and extension of multi-sectorial partner networks to finally achieve sustainable elimination of onchocerciasis in South Sudan. This is the end of my short contribution. I'd like to thank you so much for your attention. I'm happy to questions or comments. Thank you again.
Can we have the next recorded message, Nadia?
Yes, please, a few minutes, please.
Okay. So colleagues, if you do have questions and concerns, please drop them in the chat box. As you can see, we are lagging behind time, so we have to catch up on time. You can just drop your question, and colleagues from the NTD program and other partners or donors supporting South Sudan can chip in and respond to questions. Let's not just wait for the discussion slot time for the questions. Yak, please feel free to respond to some of the questions already asked in the chat box.
Hi, and my name is Sajid Kamal, and the Director of Community Initiative. Mental Initiative has been an active partner of the Neglected Tropical Disease Department in South Sudan since 2017. I'm going to present to you role and contribution of the Mental Initiative in harm coordination efforts in South Sudan. This is the outline of my presentation, where I'll show you the map, where I'll give you a brief last year's India campaign and the challenges that we faced and plan for 2023. This map shows onco endemicity in South Sudan. As you can see from the map, that more than half of the country is endemic for onchocerciasis. But I'm not going to say anything about this. The Director Yak is going to give you more details about endemicity of onco. This map shows Mentor's initiative target counties where India was conducted last year and where we are going to conduct India in 2023 again. Mentor Initiative also conducted India campaigns in 2017 and 18 and 2018 and 19 in Greater Western Equatoria. So this year and last year we have 7 counties, but 4 of them are in Mahaman. These counties either share borders with Sudan, Ethiopia, or with both in case of Languchak. Last year, we engaged Puma Health Initiative workers in counties where they were functional. We recruited and trained and engaged 3,493 CDDs, 352 Puma supervisors, 53 BIAM supervisors, and 9 county supervisors, 3 state coordinators. The total population in those counties who received IEM were 166,211. Program coverage based on CDD census was 91%. And then the same on National Bureau of Statistics census was 58%, but there are some issues with the National Bureau of Statistics census, and Director Yak is going to explain this in detail. The challenges that we faced last year were heavy rains, recurrent flooding, which delayed our MDA campaign in some counties. Population movement is very frequent. More than 60% of Sudanese are pastoralists, so they are always on the move within counties and also across international borders. The population projection for counties are not close to the reality. I've already discussed about this issue of low capacity of human resources at county PIAM and Goma level. We struggled to get CDDs and different cadre of supervisors who could read and write in some of the counties. Insecurity is endemic, and it delayed our India campaigns in Maban and Pushala last year. Travel and supplies of medicine to each county from the capital city is only by year, which make it expensive. And then there are not frequent flight to some of the counties. They get only one flight a month. So 2023, so we are going to continue the MDA campaign in all 7 counties. So we are lucky that we have received funding for those counties where we conducted MDA last year, and we are going to do it again. Cross-border collaboration with neighboring countries and advocacy for long-term government commitment for sustainability is something that MOH, Neglected Tropical Disease Department, is going to take lead on, and we will be there to support them. Thank you so much. This was the last slide. If you have any questions or any feedback, please share it with.
Thank you so much,
Hi, and
Dr.
greetings to you all. My name is Ajit Kamal, and I'm the Director for Mentor Initiative.
Please
Mentor
stop this
Initiative
presentation.
has been an active partner of Neglected Tropical Disease Department in South Sudan since 2017. I'm going
And
to present to you role and
yeah,
contribution
we
of the
can
Mentor.
stop this presentation. Okay, thank you so much to Dr. Kamal and Yohan. As you can see, we are really behind time. We are now going to move to cross-border issues. Because of the time constraint, I'm not going to allow all the presenters to take the floor. We have recorded messages. I'm going to ask my colleague at the IT to share the recorded message from DRC by Dr. Jean-Paul Tambwe and Dr. David Ogutu from Uganda regarding the presentation by Ethiopia and Central African Republic. We are going to share the slides in the folder that you'll be receiving. Let's have the presentation from DRC and Uganda. Nadia and colleagues, over to you. En France, on peut avoir la présentation de la RDC?
Oui, alors c'est pas une présentation orale. Monsieur Georges Mana va présenter en direct.
Non, on n'a pas le temps pour Hermana. On n'a pas le temps. Je demande à ce qu'on passe la présentation de la RDC et de l'Ouganda.
Pardon, je n'avais pas compris. Je suis à vous tout de suite.
Désolé, aujourd'hui, nous avons eu beaucoup de problèmes techniques. Si on doit passer toute la présentation, on risque de quitter ici à 17h, 18h. Je suis désolé pour ça. Ou bien, si celle de l'Ouganda est prête, vous nous la projetez pendant que vous préparez celle de la RDC. Yak, we do have some questions in the chat. Please feel free to respond to some of the questions. And we have also donors, implementing partners supporting South Sudan. Please feel free to chip in and to respond to some of the questions raised. En France, la présentation. Merci beaucoup. Let's start with DRC. Le volume est très bas.
Entre la République démocratique du Congo et le Soudan du Sud. La diapositive qui est devant nous nous montre en fait la situation de l'onchocercose en RDC. Et comme vous le voyez, il y a 270 zones de santé qui sont endémiques à l'onchocercose est éligible au traitement dans lesquels nous faisons effectivement des distributions de masse de médicaments à l'ivermectine. Et la partie qui nous intéresse le plus, c'est celle qui est à la frontière entre le Soudan et la République démocratique.
Nadia, on ne sait pas voir
Là, vous
le
voyez
dia.
qu'il y a deux provinces qui font frontière avec le Sud-Soudan. C'est la province...
Non, on ne voit même pas les dia en France.
Okay,
Si la présentation du Soudan, yes, please. Si la présentation de l'Ouganda est prête, on commence avec celle de l'Ouganda, le temps de fixer le problème avec celle de la RDC.
These are recordings. Will you show the recordings?
Nadia, I have difficulty to share his presentation. So in the meantime, if you could share the presentation of David Ogutu.
I have only the recording. I don't have a presentation. So maybe I can, Dr. Tambwe, do you want to give a live presentation and I share your slides? Dr. Tambwe?
Docteur Jean-Paul, est-ce qu'on peut partager vos dias pendant que vous parlez? C'est OK, Dr. Tambwe?
Si le...
Oui, on va projeter et comme ça, vous allez parler là où vous êtes. Ça vous va, Dr. Jean-Paul? Docteur Jean-Paul?
Est-ce que vous m'écoutez?
Nadia, on a des problèmes avec. Nous vous écoutons.
Allô?
Est-ce que vous pouvez parler? Can we have the slides on diaporama? Oui, on vous écoute. Parlez. Parfaitement.
Je voulais savoir si vous m'écoutez et que je peux continuer.
Nous vous écoutons. Moi, personnellement, je vous écoute. Vous pouvez parler.
OK. Je disais merci beaucoup pour la parole accordée. Nous allons vous présenter quelques éléments en rapport avec la collaboration transfrontalière sur l'élimination de nos conséquences entre la RDC et le Soudan du Sud. La diapo. Oui, la diapo suivante. Diapo.
Elle est déjà là avec la carte.
OK, voilà. Nous, tel que vous voyez sur la carte, c'est la situation épidémiologique de l'onchocercose en République démocratique du Congo, où vous avez en rouge les zones de santé, certains appellent districts sanitaires, qui sont endémiques à l'onchocercose, mais aussi éligibles au traitement de masse. Et le total, c'est 270 zones de santé dans lesquelles nous faisons la distribution de masse de médicaments. Et comme la partie qui nous intéresse pour le moment, c'est la zone transfrontalière entre la RDC et le Soudan. OK. Et lorsqu'on regarde cette carte,
oui, Nadia.
Ouais, lorsqu'on regarde cette carte, on sent qu'il y a deux provinces qui font frontière avec le Sud-Soudan. Okay. C'est le Haut-Touélé et l'Ituri. Vous pouvez aller sur la diapo suivante qui montre en fait beaucoup plus grand la carte. Diapo suivante. Diapo.
Elle est déjà là.
Est-ce qu'on peut aller sur la diapo suivante?
La dia est déjà là, Jean-Paul. Jean-Paul, pouvez voir votre écran?
OK, voilà. La connexion est très instable, donc nous allons aller progressivement. Alors, quand vous voyez la carte au niveau de la zone transfrontalière, nous avons du côté de la province de Haut-Ouélé, il y a 4 zones de santé qui font frontière directement avec le Sud-Soudan, dont 2 zones, Dourouma et Aba, qui sont endémiques à la filariose lymphatique.
Ouais, c'est bon, je suis en meeting. Là.
Dans lesquelles nous faisons...
Je suis en meeting, là.
Vous dites?
Allez-y, docteur Tamboué, allez-y.
Dourouma et Aba. Vous êtes en train d'interpréter? Voilà. Donc, il y a les 2 zones de santé qui sont endémiques à l'AFL et dans lesquelles nous faisons le traitement semestriel à l'albendazole. En ce qui concerne l'onchocercose, pour la province de Haut-Ouélé, vous avez les 2 districts sanitaires, Dungu et Faradje. Et lorsque vous prenez la province de l'Ituri, vous avez 2 districts sanitaires aussi, c'est Laïbo et Adi, qui sont en fait endémiques. Donc, ça nous fait 4 districts sanitaires qui sont dans la zone transfrontalière, qui font directement frontière avec le Soudan du Sud. Et dans ces zones de santé, on a commencé les distributions de masse années de traitement à l'ivermectine. Et c'est le son est là. Bon. Et nous sommes pratiquement à... Oh là là, j'ai perdu. Voilà. Donc, nous sommes pratiquement à 15 années, comme je le disais, de distribution de masse de médicaments, essentiellement l'ivermectine, une fois l'année. Et avec ce nombre d'années, nous avons assez pour pouvoir mener les évaluations et voir quelle est la situation qui se présente dans ces zones de santé. Et en 2020, on a mené des évaluations de routine dans 2 districts sanitaires. C'était Niangara, un peu au sud des zones qui font frontière. Et là, nous avons étudié les biopsies cutanées exsangues pour voir un peu ce que donnait le traitement. Les résultats étaient très encourageants parce que tous les villages qui ont fait l'objet de cette évaluation ont présenté des prévalences en dessous de 5%. Diapo. Diapo.
Elle est déjà là, elle va arriver.
Est-ce qu'on peut avoir la diapo suivante?
Elle est déjà là, c'est votre connexion qui est lente. Elle va arriver, elle va atterrir d'un moment à l'autre.
Apparemment, certains n'écoutent pas, ils disent qu'ils ont des problèmes de son. Bon, en
Oui.
collaboration avec le Sud-Soudan, nous pouvons dire qu'il n'y a vraiment pas de collaboration formelle entre les 2 pays dans le cadre de la lutte contre l'onchocercose, mais il est quand même important que cette collaboration soit mise en place pour pouvoir travailler ensemble et aller vers l'élimination. En quoi va-t-elle consister? Il faut qu'il y ait en fait des rencontres transfrontalières au cours desquelles l'état des lieux de la lutte est fait entre les 2 zones transfrontalières et à l'occasion, on pourra planifier les activités ou les actions communes pour pouvoir aller de l'avant vers l'élimination. Mais il y a 2 grands défis qui demeurent. C'est d'abord le défi sécuritaire, parce que dans cette zone, ces zones où il y a eu trop un certain nombre d'armées, notamment les rats, les Mororo et les groupes armés locaux, mais aussi des problèmes financiers parce qu'il faut mobiliser suffisamment de ressources, effectivement, pour commencer toutes ces réunions et toutes ces planifications. Mais côté Soudan, ils ont soulevé aussi ces défis. Et parfois la communication est difficile, limitant ainsi le travail d'ensemble. Voilà en résumé ce qu'on pouvait dire par rapport à la collaboration transfrontalière entre les deux pays dans la lutte contre l'onchocercose. Merci.
Merci beaucoup, Dr. Tambwe. Pendant que Nadia prépare la dia de l'Ouganda, we are sorry for the translation. I think you saw the text message from our IT colleagues. This is due to poor network from Dr. Tambwe's side. We are really sorry for that. We have the recorded message from Uganda. Thank you. Le message enregistré arrive. Nadia, en France.
Vous le voyez pas?
Pas du tout. À mon niveau, pas du tout. Peut-être les autres, mais pas moi. Il y a des dias qui sont passés et puis on les a plus revus.
I am glad to give you an insight of the progress.
Est-ce que c'est bon maintenant,
cross-border
Didier?
collaboration between Uganda
Nous voyons,
and
c'est
South
juste
Sudan
l'audio, on ne voit
to
pas le
eliminate
diapositive.
onchocerciasis.
Peut-être qu'il y a quelque chose qu'il faut faire pour que le diapositive puisse sortir aussi. Et là, ce qu'on entend, c'est l'audio seulement.
Je ne comprends pas pourquoi ça ne marche pas. Je suis désolée, d'habitude IT nous aide. I will share, I'll try to share it now.
I am glad to give you
Okay, it's working now.
progress of cross-border collaboration
Ça
between
marche maintenant.
Uganda and South Sudan to eliminate onchocerciasis. Just a bit of history. When Uganda launched onchocerciasis elimination in 2007, the Uganda Onchocerciasis Elimination Expert Advisory Committee was formed. Their first session in 2008 identified cross-border transmission as a major issue which Uganda needed to address to make progress towards the disease elimination. At that time, APOC promised support. We tried the first attempts to collaborate with DRC, but there were issues. In 2013, we did strategic meetings with the South Sudan, DRC, but things never worked out. Later, in 2013 still, the Ugandans went to Congo and things were not good. So when APOC closed in 2015, this was like the end of cross-border collaboration discussions. We had to adopt new strategies. For Uganda and South Sudan, what we used was now we abandon issues of bringing countries together and we engage the local communities which share the transmission zones. These communities and the local government, decentralized government, share a lot in common. They share same culture, same diseases, and they also share same security issues. So they usually come together to discuss cross-border security issues. So we had tried on this. This approach really worked, and it enabled us to begin cross-border activities. So we started mapping together with South Sudan using OV16. We did the entomological capacity strengthening and entomological prospections in the South Sudan. We only hold meetings to update the stakeholders on the progress made. So the local systems have enabled Uganda and South Sudan to make progress on cross-border. This is the area within the boundary shared between Uganda and South Sudan, and that is the Madi North focus, which shares with the Magui County and Kajukeji County of South Sudan. Flies have no borders, and that is how they behave. In 2017, we started exchanging communications, South Sudan writing to Uganda, Uganda writing to South Sudan. Local means, these are letters from the programs, and then the county administrators, county leaders. Not national, not WHO. This was our first visit to South Sudan. We formed a multi-sector team. It has security personnel, it has customs officers, immigration, so very comprehensive. Even wildlife were also incorporated into this. So we're really a complete team to support cross-border. So far, we had collaborative meeting. You see here, the first photo here is cross-border meeting, NTD program representatives from ministries of health, Uganda and South Sudan, and the local stakeholders whom we had mapped out. We trained the South Sudanese in entomology, river prospections, and we trained them also in OV16. We did all this because Uganda was much ahead of South Sudan, and South Sudan needed a lot of capacity building in this collaboration. We have made several achievements from this cross-border collaboration. We have understood the vector species in both South Sudan and Uganda in the shared transmission zone. We know in Magui there is both Levi and Amnosam. Uganda side there's the Mnosam, Kajukeji there's the Mnosam. So we understand the ecology and what we have to do. We have done entomological and epidemiological mapping, past listening for South Sudan. We have made up multi-sector stakeholders who now make it stronger that we can work without fear. We know the transmission status in both Uganda and South Sudan, and it has helped us to know that we can really make progress to complete elimination if we address few things in entomology. MDA in refugees, there are many refugees from South Sudan who are settled in Uganda. So we are conducting now mass treatment to ensure that refugees don't stay with microfilariae, and they also don't introduce it to areas of Uganda where the vector is still at large. These surveys provided evidence of reclassifying Madi North focus of Uganda from transmission ongoing to interruption of transmission suspected. The major challenges we have faced are episodes of insecurity. Sometimes this happens in South Sudan, but so far so good, they are reduced. COVID-19, this affected us so much during 2022. Our collaborative activities went to standstill because of travel restrictions. South Sudan program has no partner supporting cross-border activities, so we all have to share the little which the Carter Center provides to the Uganda program. South Sudan still implements annual MDA, while Uganda, we started semi-annual MDA many years ago. The areas of South Sudan are not delineated. The South Sudan program does not know how far these foci go north into the Sudan. So they need to be delineated. We have not had high-level coordination by WHO, very serious. So our minister has written letters to the WHO regional director, but there has been no response. So WHO has not played a pivotal role in our cross-border collaboration. In the way forward, we'd like to carry out entomological monitoring in South Sudan and also Uganda. We continue until elimination is achieved. We want to synchronize MDA and advocate for partners to support South Sudan across border activities. This is a collective effort which we should carry out. No, WHO can help us in this. We need to hold periodic cross-border meetings, like after every 1 year or 2 years, to update our key stakeholders on the progress we have made in this collaboration. Thank you very much. I want to thank all these partners who have supported us to make progress. Thank you very much.
Thank you so much to Uganda for the progress made so far and the support provided to South Sudan, Republic of South Sudan. Happy to see some cross-border activities with the Republic of South Sudan. Thank you also for highlighting some of the challenges. But I would like to follow up. I will follow up with you on the letter that you mentioned from the Ministry of Health of Uganda to the regional director of WHO. When was the letter sent? And I can follow up from that. We can have a separate meeting on that so that we can see how we can support and play a pivotal role as mentioned. Colleagues, we are going to close in 1 minute. I'm going to give the floor to Yak for some closing remarks. We are really sorry for some IT issues today, but you are going to receive a pack containing all the presentations, recorded messages. You can go through them. Should you have 1 or 2 questions or a number of questions, feel free to drop us your emails and we'll get back to you. That said, Yak, coming back to you, please, some few words to wrap up and next steps. Yak, over to you.
All right. Thank you very much, Dr. Dedire.
Yes.
I'm really very grateful for GON WHO to organize this very important meeting on onchocerciasis. I appreciate this initiative because we have a lot of things to discuss with on onchocerciasis in South Sudan. And the few challenges that I have presented, in fact, they are not few. If you can see that we have money to treat the all endemic counties in South Sudan last year, a total of 48 counties. We were expecting that the momentum that we have gained should not be lost. And if you look now, we are going to lose it, simply due to the funding issue. At the movement, we need like $851,000 US only to treat 16 counties. This is the missing the funding to achieve the 100% geographic coverage of last year. And it's very difficult for the program to mobilize those resources. As Didiri, you know very well, it's not easy here to mobilize local resources to fill the gaps. in Onko. It's not easy. And I really appreciate you because last week when we were in Brazzaville, you fled to support 9 to 10 counties. That one will reduce this now to the level of half of the missing the funding for the counties. I hope that WHO also will raise to level that you can cover all these, you can provide only 951,000 to treat all onco-endemic counties in South Sudan. And in fact, I made it clear to our local WHO here in South Sudan that why should WHO jump more to fill the gap that we still remaining. The major issue here, and I think somebody raised it here, is that we don't know the breeding side of onchocerciasis. And all of us, we know that the transmission is local. And we are still treating all endemic areas. So the issue here is whether we will be able.
1 minute left.
Yes,
please.
To provide entomological
You have already elaborated. You have already elaborated in your presentation on mapping needs,
yes.
on scaling up.
Okay.
Yes, 1 minute.
Thank you very much. Anyway, I would like to appreciate everybody who is participating here. There was the issue of CR. In fact, we need to catch up with CR and DRC. It's very challenging. If the WHO can be able to link us so that we can know exactly what can we do along our cross border that have really, we don't know that they have active transmission or not. We know that our side we are treating them, but we don't know what is happening on that side. If the WHO can be able to facilitate this so that we can have at least a planning meeting to share all information in both sides, it will help both countries. That is what I want to. Otherwise, thanks you very much for organizing this meeting. It's really fruitful. I would love that you give me more time so that I can explain everything, but the time was.
But unfortunately, due to other commitments, we cannot spend the whole day. We have the slides. We are going to have a separate meetings, satellite meeting, to have a kind of a deep dive on the issues. And WHO, I promise, will play the pivotal role, as mentioned by the colleague from Uganda. Ladies and gentlemen, it was a pleasure having you so many today for this webinar. We are really sorry for some of the IT issues. We do apologize. We do apologize also for translation issues, not due to poor internet network. But I think through the slides that we are going to share, you are going to get all the necessary information. As I mentioned earlier, should you have questions related to cross-border issues, mapping, scaling up, scaling down, breeding site assessments, please feel free to drop an email. Maybe we can organize a separate meeting, as I mentioned, and we can invite a wider group to look at the issues in South Sudan and neighboring country. Once again, thank you so much, and wishing you a very good afternoon, good evening. Thank you. Bye-bye.
Thank you, everybody. Bye.
Thank you.
Bye.
Bye.
Au revoir.